Bismillah ar-Rahman ar-Rahim. I would like to welcome you in these coming few lectures. I am Dr. Abdulaziz Al-Naqidi. I am a professor of radio diagnosis, and I have the pleasure to teach you the basics of interpretation of high-resolution multi-detector CT of the lung. When I was a resident about 25 years ago or more, we have old-fashioned CT, which was a single slice one. It was very slow. And at that time, there was a specific examination requested by our colleagues in the chest department called high resolution of the chest. It was done by thin collimation, 1 millimeter thickness, high resolution algorithm, increasing the milliampere and kV, and sometimes doing target reconstruction of a certain area of the lung. There was two techniques in this old-fashioned high-resolution CT. Either we cover the whole lung, and this was the commonest, 1 millimeter thickness, then a gap of about 9 or 10 millimeters, then rescan again 1 millimeter. So there will be an area of about 9 millimeter skipped. Or to do these high resolution cuts, 2 slices at the hilum and 3 to 4 slices at the base of the lung, assuming that most of the interstitial lung disease occur at this area, but this is not correct at all. As you see, we can miss a lesion in the areas of the gaps between slices. Thanks to technology, we are living in the era of multi-detector or multi-slice CT. Now, any multi-detector CT of the chest is high resolution by itself. What you need is just to ask the technician to make a sharp reconstruction of the data set and send it to you on the workstation to do whatever you want to do as regarding reconstructions and so on, as we will see in few seconds. Let me compare the old one and the recent multi-detector CT high resolution. In the old one, we do coverage of 10% of the lungs, but in the multi-detector, we cover 100%. Lesion can be masked in the gaps, but here, no missing. More radiation dose in the old one, less radiation dose in the multi-detector CT. We do it in axial plane only, but here we can do 2D and 3D reconstructions, which are very important. As all of you know, multi-detector CT started with 2, then 8, 16, and so on, and now have reached a huge number. As we increase the number of the detectors, more data acquisition per rotation is taken, and this results in less scanning time, which is very important, better image resolution, and better 3D and 2D reconstruction. Add to this also, as we increase the number of detectors or slices, the radiation dose to the targeted area also decreased. Multi-detector CT allowed us to scan the whole chest in a single breath hold in about 4 to 10 seconds, making respiratory motion artifacts very unusual. Also, as the technology improves, the single rotation of the tube around the patient decreases to about less than half a second, which allow us to decrease the effect of cardiac pulsation artifacts on the image. The ultra-thin slices thickness of about 1 millimeter are reconstructed at intervals of about 0.5 millimeter, allowing us to get what is called isotropic voxel. This isotropic voxel is very important to make perfect quality of the 2D and 3D reformatted images. When the examination finishes on the table of the CT, the dataset are sent to you on the workstation. And here is your rule. You should do a lot of reconstructions, including 2D and 3D reformation. The 2D reformation includes MPR, MENIP, and MEP, and 3D reconstruction includes volume rendering, virtual bronchoscopy, and bronchography. Let us detail these types of reconstruction. Multiplanar reformation. Multiplanar reformatted images are easily obtained in real time in all orientations. They even describe it as if you are doing sonar using the probe. You can go anterior, posterior, right, and lateral, and so on. You can change it to sagittal, axial, and coronal. This is the idea. Axial images, we can reconstruct sagittal and the coronal images in the same quality of images. This is very important because with these three orientations, we can exactly know the anatomy of the lung using the fissures. As you see, this is the major fissure and the transverse fissure, and we can tell where is the lesion exactly because the surgeon wants to know, do I am going to do segmentectomy or lobectomy or and so on. Okay. Minimum intensity projection. Minimum intensity projection. These are the voxels I told you about. Each voxel has attenuation different from the other. The lowest is dark like this, the highest is bright like this, and so on. Let us assume that the computer have an eye and is looking at this row of voxels. The order here to the computer is that please take the least attenuation of voxels to project them in a 2D image. Let us see. So the image will contain the lowest attenuation voxels chosen from the whole volume. What is the benefit of this? MENIP is very important to show the air-filled structures such as the tracheobronchial tree, even beyond the level of the segmental bronchi. We can see the smallest bronchi. And in pathology, it is very important to show us the bronchiectasis, minimal bronchiectasis and bronchiolectasis, because it can show the air-filled structures and omitting the signal from the nearby highest voxels. Another example for how MENIP is very important. Look, it can show the air bronchogram very nicely in this consolidative lesions, and we can see a small bronchi up to the near the periphery of the maximum intensity projection, or we used to call it MEP. It is the contrary to the MENIP. The idea that the order is given to the computer, please project only the highest attenuation voxels and omit the others. Let us see. Oh, it takes only the highest. What is the importance of this MEP? Number one, it change the vessels that are seen in the ordinary image as tubular structures. Number one, in soft tissue window, we can see bronchial arteries, pulmonary arteries, as if they are tubular branching structures. And in the lung window, it is very important to differentiate micronodules from the nearby vessels. Let us see. This is a 1 centimeter thickness slice in the lung. Both micronodules and nearby vessels, when cut in transverse orientation, they appear in the final image as if they are dots. You cannot know here where the vessel and where the tumor. But when we do map, it allows the vessels to be tubular in shape, while the tumor is seen nearby as a tumor nodule. This is very important. Look for this. This is a thin slice image. Can you tell, is this a vessel? Is this a nodule? No one can tell. What is this? But when we do map, oh, these are the vessels, and all of these are nodules. They have the name of tree embodied nodule, and we will know them in the coming second half of this lecture. Another example, this is a high resolution CT, thin slices at 0.5 millimeter. For me, this is totally normal. But when we have done mapping or map for this image, we can see now there are numerous tiny miliary nodule. This is a case of miliary TP that can be easily missed in this non-mapped image. Let's go to the three-dimensional volume rendering. The volume rendering is simply what it does. It gives different colors according to the attenuation of the different anatomy and pathology. So it can give jar-like, pathological jar-like appearance. These images are very nice for the clinicians because they want to see what they see during gross pathology, during surgery and so on, but actually we don't use them for diagnosis. We can present the pathology, but we usually diagnose using the 2D images. Another examination or another type of reconstruction called three-dimensional bronchography. It is used to show the tracheobronchial tree as like this. Wall, their wall is bright and the lumen is black, omitting other things. This examination replaced an old examination we used to done 30 to 40 years ago, which is called bronchography or contrast bronchography. In this technique, a tube is introduced to the trachea through the larynx, and we installed a little amount of certain type of contrast to opacify the wall of the bronchi to make bronchography. But by this technique, we can do, without any invasion, three-dimensional bronchography. The last one is the virtual bronchoscopy. The virtual bronchoscopy depends on navigating inside the lumen of the trachea and the bronchi like this image. This is very nice, and you can see the obstructing lesion and which bronchus is obstructed, and the more important thing is that you can bypass the point of obstruction and go through the bronchus distal to the obstruction, which cannot be done by the ordinary bronchoscopy. Some of our dear chest department colleagues ask for this technique. Now I will explain to you and teach you what are the normal high-resolution CT findings. Anatomy. Because if we have deviation from this normal, these will be considered abnormalities. There are some rules that you should know by heart. Let's start. As you know, we have large airways and small airways. The large airways start from the bronchi down to the bronchioles. They are more than 2 millimeters in size, containing cartilage, only conducting, can be normally seen in high-resolution CT. While the small airways start from the terminal bronchiole down to alveoli, they are less than 2 millimeters in size, containing no cartilage, conducting air and sharing gas exchange, and normally these structures are not seen in high resolution CT. So we deal with this. Okay, large airways. Let us start. Rule number 1. The diameter of an artery, which is of course pulmonary artery, and its neighboring bronchus should be approximately equal. This is the artery, it is wide, and this is the bronchus or bronchiole, it contains air. The diameter of the artery should be equal to the diameter of the bronchus. Sometimes the artery may be slightly larger than the nearby bronchus due to gravity or plethora or something like this. But if you see in high resolution CT that the diameter of the bronchus is larger than the nearby artery, it means that this bronchus is abnormally dilated. It equals bronchiectasis. Rule number 2. The outer walls of visible pulmonary arteries should be smooth, sharply defined with the interface of the nearby lung. Ill definition or irregularities of this border means that we have thickened peribronchovascular interstitium. The same is applicable for the bronchus. The wall of bronchi, outlined by lung on one side and air in the bronchial lumen on the other, should appear to be smooth and of uniform thickness. Irregularities or increased thickness of these walls means that we have thickened peribronchovascular interstitium. Rule number 3. The outer third or fourth of the lung, you shouldn't see any bronchi, air-filled bronchi. If we see bronchi in this outer third, that we have abnormally dilated airways, we have bronchiectasis. Regarding the pleural surfaces and fissures, you know we have visceral and parietal pleura, and according to its location, it is called the mediastinal or costal pleura and diaphragmatic pleura, and so on. But actually, we cannot easily see the pleura on the surface of the lung. So we use fissures to comment on the pleura. Fissures. Why? Because the fissure here is lined by lung on both sides, and usually it contains the 4 layers of the pleura. Normal fissure should be less than 1 millimeter in thickness, smooth in contour, uniform in thickness, and sharply defined. If these are not present, we have abnormal pleural thickening. Now let us discuss one of the keystones in the radiology of the chest. It is the secondary pulmonary lobule. It is the smallest unit of the lung structure marginated by connective tissue septi. The lung is made up of numerous secondary pulmonary lobules, which are the key of high resolution CT. Secondary pulmonary lobule is made up of a limited number of pulmonary acini. Acini are not visible on high resolution. The secondary pulmonary lobule is polyhedral in shape, irregularly, and their diameter ranges from 1 to 2.5 centimeters. Each pulmonary lobule is supplied to its center by an arteriole and accompanying bronchiole that reaches to the center of the secondary pulmonary lobule, while the periphery of the secondary pulmonary lobule is formed by the interlobular septi, which extend from the pleural surface perpendicular on it, and this margin or interlobular septi houses pulmonary venule and a lymphatic. Okay? This is a very magnified image of the secondary pulmonary lobule using high resolution CT. This is arteriole reaching to its center, accompanied by a bronchiole. They are of equal size. And the periphery, as you see, these are the interlobular septi that contains pulmonary venule and a lymphatic. How we can differentiate between arteriole and interlobular septum? As you see here, interlobular septi reaches to the septa, reaches to the pleural surface, and it is perpendicular on it, while the arteriole ends about 1 to a half centimeter from any pleural surface. These are the arterioles. They end half to 1 centimeter from the pleural surface, while the interlobular septi can be seen perpendicular and reach to the pleural surface. The interlobular septi extends inward from the pleural surface. They appear very thin straight lines from 1 to 4 centimeters perpendicular on the pleural surface. You can see it perpendicular on the fissures or the coastal or mediastinal pleura, like this, perpendicular lines reaching to the pleural surface. A few normal septa are often visible in the lung periphery in normal subjects, but they tend to be not very clear. If you see more than a few normal septi, this means that we have interlobular septal thickening, and we will discuss this later on. Normal septi are most often seen anteriorly along the mediastinal pleural surface. They are thinner in the center of the lung than. Let us compare. B is interlobular septum because it reaches the pleural surface, while A are pulmonary arteries. The connective tissue system of the lung is divided into 3 fiber systems. The first one is called peribronchovascular interstitium. It starts in the hilum, surround the major arteries, go along the major arteries and bronchi till the core or the central area of the secondary pulmonary lobule. The second type is called subpleural interstitium. It starts in the pleura and extends along the interlobular septi. Okay. The third one is the connective tissue filling the rest of the secondary pulmonary lobule. So let us look here. Secondary pulmonary lobule, its core contains peribronchovascular interstitium. Its periphery contains subpleural interstitium, and the rest of the secondary pulmonary lobule is supported by what is called intralobular connective tissue or interstitium. According to this, we have centrilobular area, which contains arteriole, bronchiole, and peribronchovascular interstitium. It has its own types of pathology according to these anatomical structures. While The periphery of the secondary pulmonary lobule and the pleura have what is called perilymphatic area because it contains lymphatics and venules. So the pathology here will depend on lymphatics and pulmonary venules. Again, centrilobular area and perilymphatic. Let us revise again. Look for these nice diagrams. Secondary pulmonary lobule, the center contains artery, while the periphery contains the interlobular septum, which contains vein, lymphatic. This is the visceral pleura through which the interlobular septum. The lymphatics, as you see, are running in the interlobular septum. A good radiologist is the one who can identify artifacts and not over-diagnose them as pathology because they are just artifacts. The physiological atelectasis that disappear on the prone position. Window settings. Regarding window settings, there is no normal or no 100% correct or ideal window settings. There are what is known as the preferable window setting according to your eye and your idea and according to what you are looking for. As you know, we look for the chest in the soft tissue window, which is called the mediastinal window, and the lung window. The most preferable one is minus 700 over 1000, and as you see here, there is the chest wall is very wide and the mediastinum is very wide. We just look for the lung. This is the most preferable. There is another window setting called extended window, where we increase the width. Here we can see some details of the chest wall, and this allows us to comment on the pleura. Okay? The other one, or the last one, is called narrow window width and length and width. We do it minus 800 to 900, and the width is less than 800, it is about 500. This one has importance and has a drawback. The drawback of this window is the fallacious diagnosis of a thickening of the wall of the bronchi. This is fallacious. So if you do this narrow window, don't diagnose thickening of the wall of the bronchi. What is its importance or its value? It can show areas of air trapping easily. Okay, so its value is to show areas of air trapping, and its drawback is the fallacious diagnosis of bronchial thickening. I will stop here. The second part will be the abnormalities. You can take some rest.